Hi everyone, we are talking about pain assessment and management, and this is for preparation for your clinical practice. So learning the techniques and approaches and engagement is essential for effective nursing practice across the lifespan. So before we begin, there's copyright that you need to take account of, and in this session what we're going to do is explore the introduction to pain, explore pain assessment, examine some standardized pain assessment tools that we actually currently use in practice, and consider some special considerations in relation to pain assessment, promote documentation and communication, and identify barriers to effective pain assessment. So the definition of pain is actually from the International Association for the Study of Pain, the IASP 2020, and that is the most recent definition that all healthcare workers and all healthcare contexts actually work with. So it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So it's always a personal experience that is influenced to varying degrees by biological, psychological and social factors, and we're going to explore some of those. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. And throughout one's life, individuals learn about the concept of pain, and a person's report of an experience of pain should always be respected. So although pain can serve as an adaptive role, it may have adverse effects on function and social and psychological well-being. And for that reason, verbal description is only one of several behaviours that actually are examined in relation to the expression of pain. The inability to communicate doesn't negate the possibility that a human or a non-human animal experiences pain. So the physiology of pain, I'm not actually going to cover that, but just know that there are pain transmission pathways that work on principles of transduction, transmission, perception and modulation. There's the gate control theory, there's the neuromatrix theory of pain, and in your biological units, the bioscience units, you'll probably explore the physiology of pain. But when we're working with patients, what we're looking at is a patient's type of pain and perhaps their response to that type of pain as well. So we know that there are acute versus chronic characteristics, nociceptive pain, that is somatic and visceral, neuropathic pain mechanisms, inflammatory pain, and there are mixed pain syndromes. So when we're trying to understand acute pain, for example, it's elicited by injury to body tissues. It's typically seen with trauma, acute illness, surgery, burns or other conditions of limited duration, and are generally relieved when healing takes place. When you compare this to chronic, this is elicited by tissue injury and can be perpetuated by factors remote from the original cause and can extend beyond the expected healing time and generally lasts for 3 months or longer. So now when we look at the nociceptive pain, this is noxious stimuli that damages tissues or has the potential to do so. So if the stimuli are prolonged. Somatic pain, this arises from skin, muscles, joint, connective tissue or bone, and are generally well localized and described as aching or throbbing. Visceral pain in comparison arises from internal organs such as the bladder or intestine, and it's poorly localized and often described as cramping. So your neuropathic pain is actually caused by damage to peripheral or central nervous cells, central nerve cells. So the peripheral, this arises from injury to either single or multiple peripheral nerves, and these are felt along nerve distributions. So it could be burning, shooting, stabbing, or like an electric shock. And diabetic neuropathy, hepatic neuralgia, radiculopathy, or trigeminal neuralgia. Central nerve cells, these are often associated with autonomic nervous system dysregulation, phantom limb type pain, so that's in our peripheries, or complex regional pain syndromes, and this is a central manifestation. So you can see that just understanding the differences in the acute versus chronic and then the nociceptive pain, somatic versus visceral, will actually give you very good insight into the structures involved in the pain response, and then also the type of data that you will be interpreting as well. So when people describe their pain, they're actually going to describe it in certain words like burning or shooting or stabbing, that type of descriptor. So when we think about the impact of untreated pain, so this is why we take pain responses very, very seriously. And so untreated pain can actually have negative physiological effects. It will disrupt the immune system or the endocrine system or the cardiovascular system. And so this is why often we can tell if someone is in pain because their blood pressure may actually be much more elevated than normal. So we always look to see if, like people's responses to pain, or if they are indeed experiencing pain, because even if someone doesn't tell us about it, we can observe it in terms of physiological effects. Psychological impacts can include things like anxiety, depression, PTSD, and then there's also one of the impacts is around that there's functional limitations and disability, and there's also a risk of pain chronification. So that is the pain actually is chronic and has an ongoing basis, and so that's actually a very difficult one, because often in those situations people may not be believed in terms that they are experiencing pain. And of course there is an economic burden to the impact of untreated pain, because people may not be able to work effectively. There may be effects on family life, and so therefore the distribution of family work will actually change, which can influence economics as well. So economic burden happens at the personal level, at the familial level, and then certainly at the system and the national levels. So when we think about ethical considerations, pain relief is a fundamental human right. And if we go back to that definition from the International Association for the Study of Pain, the sheer fact that we've got an international definition, an international body that is determining the appropriate definitions and changes to definition, actually tells us that pain relief is a fundamental right. Ethical principles are applied in pain management, so this is both beneficence and non-maleficence, and as you engage in your governance unit, your inquiry unit, you will understand that in terms of nursing practice, beneficence is to do good and non-maleficence is to do no harm. So when we're selecting our pain management approaches, it's always to do good, to do the person some benefit, and then non-maleficence is to do no harm. So i.e. we don't want to give them the wrong medication for the wrong type of pain cause that or the cause of pain that might be in process. And of course what we do is address disparities in pain treatment, and so, for example, when we think about our palliative teams, palliative pain management teams, they look at some of the disparities in pain treatment and have addressed over time the requirements around breakthrough pain management. So yes, you have your regular pain management, but then people can have breakthrough pain. And so therefore ensuring that people's pain, irrespective of causation, is actually managed well becomes very important. And balancing pain relief is always with that risk management hat on. So when we're looking at medication safety, for example, standard in terms of the National Safety and Quality Healthcare Commission, we need to actually ensure that we are responding to medication management from a risk management perspective. Okay, so if we think about the multidimensional pain assessment, this is where we're looking at these 4 factors. So subjective, so that is what the person tells us, and self-report is the absolute gold standard. But what we're looking for in that self-report, which you will elicit when you're attending to a pain assessment, is that description of pain qualities and the perception of pain impact, or the previous pain, someone's previous pain experiences, or perhaps some expectations for pain relief. And so sometimes when we're looking at that subjective component, we might use tools like the PQRST approach to eliciting that subjective information. And so that's a great one to actually get really familiar with and be comfortable in your repertoire of assessing pain. Objective components are also part of that multi-dimensional pain assessment, and this is very important because we do know that when we're caring for people across the lifespan, is that we have people who can tell us what's going on, but then we also have some very non-verbal experiences across the lifespan, from being very young, i.e. birth, from a young baby, right through to an older person who may not be able to express their pain, or who may have some cognitive changes, or may indeed be unconscious, and therefore they can't tell us what's going on. So your objective components are important as well, and these are your physiological indicators, so your vital signs, any lab values. So when we're thinking about immune responses, for example, we're going to see changes in relation to our CRPs in the absence of infection, because that's, if someone has a systemic infection, there may be a visceral response, and therefore we're going to see how that might manifest in the body, and they may not necessarily tell us about that, but that's what we're going to observe. We also assess for a number of behavioural cues, facial expressions, body positioning, that guarding process that goes on. Our functional assessment is going to tell us what one can do and what one can't do. So, like if you're able to carry out your ADLs independently and without assistance, or within a reasonable time frame, those are all the parameters that we look at in terms of objective data. And then sleep and appetite changes as well, because sometimes when people are in pain, it disrupts their sleep, and it may dampen their appetite as well. And then of course examining medication response patterns, so examining physiological vital signs. Blood pressure, for example, is very important, because if we've administered some pain relief and the person can't tell us what's going on, again we'll be able to assess that blood pressure, for example, to tell us whether that pain relief has worked or not. So this is where understanding the objective component of pain assessment becomes very important. Contextual factors are also critically important because there are psychological factors at hand here, and that when experiencing anxiety or depression or catastrophizing, our pain response can actually be heightened, and so you're examining for any contextual factors, any social determinants, so they're your support system, economic factors, any cultural influences on pain perception, any spiritual or religious beliefs, and also if there are any environmental factors affecting pain. So, so the spiritual, the cultural, the religious, the social determinants are going to be very individual to that cultural group, and your environmental factors, for example, that might be affecting pain, is, for example, loud noises in response to migraines, or let's say light, that sense of high intensity lighting can affect migraine responses as well. In some contexts, pain assessment is also considered the fifth vital sign. So just as we're doing TPR and blood pressure, pain assessment is part of that sense of it's an assessment parameter that becomes important in understanding what is currently happening to that person, and perhaps some of the medical or surgical histories they might have encountered in response to pain. So pain gives a historical context and a development. There's certainly benefits for routine pain assessment as part of our standard admission assessment that we're doing, or TPR assessment, those interim assessments or 4-hourly assessments that we're doing. There's also criticisms and limitations of a pain assessment in relation to how you are collecting the data and how you are communicating the findings. So that's why gauging the aspects of how you are gathering data becomes important. And there are current recommendations for integrating pain assessment into your routine care. So when you are meeting and greeting people, when you are doing routine observations, when you're doing 4-hourly observations, certainly when you are doing admission procedures, and certainly when you are, let's say, doing a post-surgical return to ward assessment or series of assessment, because we know that people's response to pain will be there. So there are a number of standardised pain assessment tools that are actually used in the clinical areas, and these are actually very useful because some of these tools are actually non-language based, and so can be understood by people across the lifespan. So clearly it would be more difficult for babies and infants, but young children who can do facial recognition, for example, may be able to, we use those visual analog pain scales for very young children, for example, and also for people who perhaps English is not so good, because it's the sense that we make assumptions about care or about people, and so therefore there's a variety of tools to accommodate the type of situation the patient is in. So there's the numeric rating scale, there's the visual analog scale, there's a face pain scale revised, and this is a revised one, brief pain inventory, the McGill pain questionnaire, and then there are a variety of tools for non-verbal patients, and so this might relate for people in advanced dementia, critical care pain observation tools, the CPOT for example, the behavioural pain scale, the non-communicative patient's pain instrument, and the checklist of non-verbal pain indicators. So you can see that there's a tool for non-verbal patients. That's really important, because when we think about pain from an equity framework and ensuring that all people have a right to pain relief. We're applying this in an ethical way in our practice. So this is an example of a visual analog scale. So this is a 0 to 10, with 10 being the worst. And you can see that, that there's a colour rating to this scale as well. This is the numeric rating scale, and so again this is a 0 to 1 to 10, but we can see that rating scale is going from 0 being nothing to 10 being the worst it could be. For your pediatric patients, we've got the FACES scale, the poker chip scale, the numeric rating scale, or colour matching. So depending on the age of the child and their capacities, this would be an important aspect to consider as well. So this is an example of FACES, and it's combined with a numeric or combined code, and so you can see how a child would be able to respond very easily to what they would be feeling in relation to pain. For infants, for babies, we've got the Neonatal Infant Pain Scale, the NIPS. We've also got the Neonatal Pain Agitation and Sedation Scale, NPAS, and we've got the Pain Assessment Tool. So babies also experience pain, and so therefore we respond appropriately to that age bracket via developmental means. So special considerations that we're making in pain assessment. So we've talked a little bit around the tools. So in your pediatric patients, it's developmental considerations we make by age group, and we always make sure that we've got age appropriate assessment tools, and we also consider proxy reporting considerations. So that is from the parents or the caregivers in relation to their the little person they're looking after, because the parents or the caregivers understand that pediatric person in a way that we don't. Behaviour pain scales for infants, which I've mentioned, and there are common misconceptions about pediatric pain is that, for example, infants and babies don't experience pain. So in days gone by, like babies and children perhaps wouldn't have had some of the ethical care that they needed to have done. Geriatric patients, this is age-related changes affecting perception, and this is assessment and consideration with any comorbidities, pain assessment or pain presentation differences in older adults, any medication consideration, that is the pharmacokinetics and the dynamics of medications that people are on and how they may impact or exacerbate or excel some of the outcomes. And of course it's the role of functional assessment. People with cognitive impairment, we've got dementia specific pain behaviours that we're observing for, and there are a number of other observational assessment strategies that we put in place, and we also look at interpreting behavioural changes as a potential for change. So behaviour in people with cognitive impairment is a big clue, or behavioural changes is a big clue about what's going on with this person. So when someone with cognitive impairment is acting up or acting out in any capacity, we need to assess for any presence of pain. And particularly as you do your residential experiences, residential care experiences, it's important to understand those people in very deep ways, people with cognitive impairments. And you're always involving family or caregivers in that assessment, because again, they know their loved ones and their responses. So you're always looking to establish a baseline so that you can go forward. Non-verbal patients, and these might be, for example, people who are mechanically ventilated or people with neurological impairments. What we're going to do is actually look at observational pain assessment protocols, and the physiological parameters actually become really important. And then we also need to ensure that we our documentation of the challenges and solutions put in place for our non-verbal patients is actually addressed. And then the last section for consideration is the cultural, and this is cultural, that there is cultural variation in pain expression. There's language, there are language barriers in pain assessment, and so this is why we can use in healthcare the translation language, English language translation service, to ensure that we give appropriate pain assessment and overcome any language barriers. There are cultural beliefs about pain meaning and management, and there are culturally responsive assessment approaches that we need to undertake as well. And so what we want to do is avoid stereotypic responses while we're recognising individual patterns to pain. So when we think about documentation and communication, it's the PQRST method, and this is, the P stands for what's provoking or what palliates this pain that you might feel. What are the quality descriptors? So can you tell me what it's like? Is it burning, stabbing, etc.? Where is it? So where's the region, and does it radiate anywhere? What's your severity rating, and the timing aspect, onset, duration and pattern. So when we're looking at documentation, for example, our standardized pain document, we've got standardized pain documentation fields, and we see that integrated, for example, in the AORC chart, where at the very bottom of the chart there's a pain assessment that's done, and it's used a numeric scale, but it compares a pain response at rest and then with exertion. So documentation of different responses becomes really important. But if someone has got pain, you need to examine that pain in a PQRS method. We need to know people's pain responses for our interdisciplinary communication, because pain, if we're communicating pain assessment during handover or during a like a bedside handover or a medical review, knowing that detail, for example, around the PQRST, will actually help inform the type of pain medication required. So communicating pain patterns to providers, to the medicos, the doctors, the nurse practitioners who can initiate orders, pain rounds and team discussions, communicating with senior staff, so that is your clinical team leader if a person's pain responses are getting worse and you're escalating that care need, or if you're speaking directly with a medical a doctor around requesting additional pain relief. And patient-centered pain communication, patient-centered pain communication is very important. So pain reassessment is conducted at regular intervals as well, and so there are guidelines for reassessment frequency. We're always going to reassess a person's response to pain after an intervention. We're going to document that reassessment finding on the either in the patient records or in the bedside records, depending on what documentation is at hand. We may need to, and this would be more for next semester when you're using protocol drivers to reassess pain requirements, and we're also looking at any critical incidents indicators that require an immediate reassessment. So for example, blood pressure, those critical indicators. So if we think about some of the barriers to effective pain assessment, there might be some healthcare provider biases, and this is a knowledge deficit about pain mechanisms, a misconception about addiction and dependence, cultural and gender biases in pain assessment, and attitude towards certain pain conditions, or there's a personal belief about suffering and stoicism. So that's from the healthcare provider. These are the potential biases that we need to work through, and very important that you examine your own bias in relation to healthcare effective pain assessment, because you can't have a bias. You need to work with a patient-centred approach. Patient barriers to reporting pain include a fear of addiction of stigma, concerns about being labelled as difficult, a cultural expectation about pain and the expression of pain, and a misconception or a misunderstanding about pain medications, and perhaps communication limitations that I've alluded to earlier. There are system barriers that we need to also adhere to, consider, and this you'll do later on in your study journey and also as registered nurses. So it's around time constraint, workload issues, the lack of standardised protocols, limited access to specialised assessment tools, or continuity of care challenges, or sometimes the regulatory factors that that might impact the delivery of care. And strategies to overcome some of these barriers relates to education processes for healthcare professionals, patient education and empowerment, so that is whenever you're working with people and disseminating pain medication under supervision, you're always providing education and empowerment to them. And then, of course, there are system-level QI improvements which you'll do as registered nurses, technological solutions that you'll do as registered nurses, and then you will participate in improving organisational cultural responses to pain. So in terms of the guidelines and standards, for example, what I would like you to do is have a look at the Royal Perth Bentley Group Pain Management Nursing Practice Standard. This one here is because that's what you have access to, and you can see what guides practice. But you will find that depending on what tertiary setting you're going to. So East Metro covers the Royal Perth and Bentley Group. South Metro will cover Fiona Stanley, Fremantle, Rockingham and Peel Bentley groups. And then your WACS groups, you've got another set of standards that you're working with, and your North Metro, for example, nursing practice standards will cover the Sir Charles Gardner and the Osmond Park and perhaps Joondalup process management. So that's why you're always guided by the local policy and guidelines. But I just wanted to give you that scope that even in each of these health regions, there's always an acute pain service, there is always a palliative care pain service that is attended to, there's always drug and alcohol clinical nurse consultants that you can access, and there's always consultation and liaison with relevant psychiatry groups as well within each of those areas. So here, this is an example from the Royal Perth Bentley Group, and you can see that what's been indicated is the numerical rating scale that I alluded to much earlier on, and it's also the FACES group that I alluded to earlier on, but the one that I showed you was the revised FACES pain rating scale. This is the original one. So you can see how, and there's also the behavioural rating scale as well. So this is an example of the type of information that's included in the nursing practice standards. And then here, this is an example of the pain pathway models, how we're assessing for pain, any acute pain services consideration that might need to be attended to, any functional activity that needs to be attended to. So this is just, and also the pain assessment in advanced dementia care scale, so the pain aid approach. So you can see that from the content that I presented earlier, that relationship to each of the special groups becomes evident. This is your pain assessment score, so this is the pain ad for the advanced cognitive, for the advanced dementia patients, and then also when we're starting to see some of the changes in ventilation as well. So it starts to, what we're saying here is that we're all using a scoring system, and so that becomes important. This one here is around the sensory block and the motor function assessment, and so when we're looking at neurological blocks, for example, we use the Bromage scale for someone who perhaps is post epidural anesthesia or post surgical anesthesia as well. So this is just one part of the sensory block picture that you would be examining. So what I would like you to do is access the Royal Perth Practice Standards so that you can understand that in greater detail. So here are some references for you to look at. I've included the International Association for the Study of Pain and also the practice standards. So thanks everyone, and I look forward to working with you in the clinical area, laboratory and simulation, so that you can effectively assess people for pain. Thank you.